Welcome to the latest edition of the ECG 5-Minute Consult, JEMS' ECG of the Month, brought to you by paramedic Troy Kennedy, Dr. John Hayden, and myself, where we teach you foundational ECG knowledge using the primary survey approach from our book, ECG for First Responders, available on Amazon. Let's take a look at today's case. You arrive on scene to find a 77-year-old female who is a resident of a nursing home. She presents with altered mental status and is complaining of shortness of breath and lightheadedness. The patient is pale, cool, diaphoretic, and when auscultating the patient's lungs, you note bibasilar rales, or crackles. She uses home oxygen via nasal cannula as prescribed by her doctor, but states that this episode is worse than her usual shortness of breath symptoms and that the oxygen is not helping. She has a history of hypertension, CHF, arthritis, and dementia, for which she takes lisinopril, furosemide, alendronate, and ibuprofen. Let's get an ECG on this patient, and as we examine it, we can run through our primary survey approach, in which we seek to answer these 4 questions. 1. Is the heart rate too fast or too slow, causing cardiovascular instability? 2. Is the rhythm supraventricular or ventricular in origin? 3. Are the ST segments consistent with an ST elevation myocardial infarction, STEMI, or a non-ST elevation myocardial infarction, NSTEMI? And lastly, are the T waves consistent with the STEMI or NSTEMI? Now that we have this organized approach in mind, let's look at the ECG in the context of the primary survey, beginning with the heart rate. To determine the rate, let's pick an R wave that falls on a black graph line of the ECG, and then count out the number of large boxes until the next R wave appears. So with this one as our starting point, let's count large boxes going 1, 2, 3, 4, 5, 6, and 7. Then we'll take the number 7 and divide it into the number 300, giving us a heart rate of 43, which is slow. The normal heart rate range is from 60 to 100, and below 60 is considered to be bradycardic. Now, to say whether this patient is stable or unstable, we need to look at this rate along with the other components of a complete set of vital signs. So we already determined that the patient's heart rate is 43. We now find her to have a blood pressure of 74/40, a respiratory rate of 20, an SpO2 of 88%, and a temperature of 98.6 degrees Fahrenheit. So given the fact that this patient is hypotensive with signs of shock, hypoxia, and altered mental status, this patient is definitely unstable with this rate. Assessing the rhythm, we see that each QRS complex is preceded by a P wave. And though the rate is very slow, the R waves are marching out at consistent intervals, meaning this rhythm is regular. Looking more closely at the QRS complexes, they appear to be narrow, that is less than or equal to 3 small boxes wide, or 0.12 seconds. R's seem to be about 2 boxes wide, or 0.08 seconds, which means that this rhythm is most likely supraventricular, originating from above the ventricles, making this rhythm sinus bradycardia. Now we will take a look at the ST segments. The ST segment is the interval between the end of the QRS complex and the beginning of the T wave. Between each QRS complex, the ECG stylus should return back to the baseline, or isoelectric line, which is the flat line between the end of the T wave and the beginning of the P wave. We'll compare our ST segments to the isoelectric line in each of these leads, which we'll highlight here in green. We are checking for any ST elevation, which usually indicates infarction, the death of myocardial cells, or depression, which usually indicates ischemia, inadequate blood supply, or infarction in the case of a non-ST elevated myocardial infarction, NSTEMI. Our ST segments appear to be congruent with the isoelectric line with no ST changes. Lastly, we will take a look at the T waves. When assessing T waves, it is important to understand that T waves are normally inverted in leads AVR and V1. Scanning through the rest of these leads, there doesn't seem to be any T wave inversion, though we do see some T wave flattening in lead 3. It doesn't correspond with any ST change and is otherwise unremarkable. Overall, these T waves are normal. Now that we have used the primary survey to assess this ECG in an organized manner, let's make a decision on the course of action regarding this patient's care. Which of the following choices do you think is the most appropriate next step given her bradycardia and hemodynamic instability? Would it be A, immediate synchronized cardioversion, B, 1 mg of epinephrine 1 to 1,000 concentration IV, C, 15 liters per minute oxygen via non-rebreathing mask, D, 0.5 mg of atropine IV, or E, a 250 milliliter normal saline fluid bolus? The correct answer is D. Give 0.5 milligrams of IV atropine. Now, this is a bit of a tricky question in that giving oxygen is totally appropriate, just not the next best step, as we need to give the atropine quickly given her unstable bradycardia. And a fluid bolus would also be appropriate, except is contraindicated in our case, as the patient has a history of congestive heart failure and has bibasilar rales or crackles on auscultation of the lungs, which is suggestive of fluid overload secondary to her heart failure. Also important to note that while you're drawing up the atropine, your partner should be applying pads to the patient. Per ACLS guidelines, if the patient has symptomatic bradycardia and is unstable, give atropine 0.5 milligrams IV every 3 to 5 minutes up to a max of 3 milligrams. And if the atropine is still not effective, the next best step would be to begin transcutaneous pacing. In the case of a second-degree type 2 or third-degree heart block, it could even be reasonable just to go directly to pacing. Now, if neither the atropine nor the pacing is effective, you may need to employ pressors and/or contact your base hospital for expert consultation. But if you do give pressors, please do not give the 1 to 1,000 concentration of epinephrine IV, as that could severely harm the patient. IV epinephrine is administered in the 1 to 10,000 concentration, which is much more diluted and is not given at 1 milligram, but rather at 2 to 10 micrograms per minute, per the ACLS bradycardia algorithm. So make sure you're double checking that you have the right concentration of the right drug before giving it. And in the context of her history of congestive heart failure, dobutamine may actually be a better choice for hemodynamic support. That's all for today. We hope you've enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about ECG interpretation, check out our book, ECG for First Responders, available on Amazon. Thanks for your support. We look forward to seeing you again next time.